presentation is multiple approach to mitral valve procedures on perfusion techniques. I have no disclosures at this time. So just a little introduction. Traditionally, mitral valve surgery has been performed with a conventional open sternotomy. In recent years, minimally invasive techniques have become more popular with the goal to decrease surgical trauma and improve several aspects of patient outcomes. Increasing demand for even less invasive mitral valve surgery has led to robotic techniques that allow for precise and durable repairs with even smaller surgical incisions. So for this presentation, I'm going to be discussing 3 different techniques for mitral valve repairs. It's going to be the open conventional sternotomy groups, minimally invasive via right mini thoracotomy, and then totally endoscopic robotic repairs. So for the median sternotomy, this is just your traditional open with a direct cross-clamp, bicaval venous cannulation, direct arterial cannulation, and then for my study, it was del nido antegrade cardioplegia that was given directly into the root. For the mini mitral repair, the mini thoracotomy, which for the rest of the study I'm just going to refer to as mini, a 6 to 8 centimeter incision was made between the 3rd and 4th intercostal space, a femoral long venous and direct central arterial cannulation, a flexible cross clamp was used to the aorta, and then del nido was also given antegrade into the root. And then just a couple photos here where you can see the difference in incision and then how the cardioplegia is set up there. For the totally endoscopic mitral valve repair, the Da Vinci system was used, and then that photo on the right is just a representation of all of the different ports that were placed. There were 5 1 to 2 centimeter incision ports, a femoral long venous arterial cannula. We use the endoscopic balloon aortic clamp, so for those that are unfamiliar with that setup, it's thread up the arterial cannula femorally, and then it's a balloon clamp that's inflated to cross clamp from the inside. And then del nido antegrade cardioplegia is given through that endoclamp system. So just some background studies on minimally invasive surgery. This was one study that evaluated 4,000 patients who underwent isolated mitral valve repairs. It showed that the overall hospital mortality was 1.3% for both the mini group and for open repairs. So there was no difference in perioperative stroke, and then hospital stay, risk of bleeding, and need for transfusion were all proven to be less with the mini thoracotomy group. This led to improved cosmetic, reduced postoperative pain, and fewer infections with a faster return to activity. And then another study that focused on robotics. This was 500 patients who underwent totally endoscopic robotic repair, showed that complex repairs were able to be performed when completed with superb results. There was an increase in operating room extubation rate, a decrease in hospital length of stay, and then no significant difference in number of neurological incidents. So basically, prior research has showed us that minimally invasive does all these great things: reduced pain, less bleeding, fewer wound infections, shorter postoperative length of stay, cost reduction, cosmetic results, less mortality and morbidity. However, there's only been one study that was published that's actually compared these 2 different forms of minimally invasive techniques, and then there really hasn't been any that have focused on the perfusion aspect of that. So the purpose of my study for my thesis presentation was to examine the adequacy of perfusion for open conventional sternotomy, mini right thoracotomy, and totally endoscopic robotic repairs, evaluating patients' blood pressure, venous saturation, urine output, increase in lactate, and oxygen transfer and demand to show that low flow index is easily tolerable while the patient is well managed. So hypothesis for this was perfusion techniques for both minimally invasive operative approaches will have lower flow indexes and longer bypass times, but does not affect the outcomes and provides adequate perfusion when compared to conventional sternotomy. So my methods, this was a prospective study that evaluated 150 patients in 3 separate groups undergoing mitral valve repairs, 50 in each group. These were all isolated repairs with no other interventions, and patients that were excluded were those that either had prior kidney issues or past neurological history or event. Cerebral saturation was also used to ensure that there was no drop of more than 10 points below baseline, and then I used a one-way ANOVA test for statistical evaluations. So just looking at the results for bypass time, for each variable I looked at both mean and median. However, all were fairly close in value, which shows that the variables had good control. So for purpose of confusion, when I'm going through all of these, I'm just going to talk about the means. For bypass times, robotic procedures proved to have significantly longer times with about an average of 134 minutes. Cross-clamp times showed a similar pattern to the bypass times, with robotic being significantly longer than both of the other groups and an average clamp time of 91 minutes. Flow index, so the results for average flow index throughout the case can be easily seen when you look at this graph. There were significant differences between each group, with open having the highest average at about 2.2, mini at 1.9, and then last, the robotic at a flow index of 1.57 on average. So blood pressure was recorded from a left radial arterial line and was found to correspond with the same pattern as flow indexes. Each group showed significant difference from each other, with open having the highest, then mini, and then robot with a map of 53 on average. However, again, like I mentioned earlier, cerebral saturation was monitored to make sure that this drop in blood pressure didn't lead to a drop in cerebral saturation. Venous saturation followed the similar pattern, significant differences between each group. However, with robots being the lowest, the venous saturation still showed to be about 73% on average. So I added that red line there to the graph just so you can see that's where 65% would be, which is typically what we think of as the lower end of adequate. So almost all patients from all groups were still above that. Urine output was monitored and values were calculated in cc's per kilogram per hour. Again, these values correspond with the flow index. On average, the robotic group was the lowest with about 1.5 cc's per kilogram per hour, and then I also added that red line again so you can see where 1 cc per kilogram per hour would be, which is what we would consider typically to be the low end of still adequate. Increase in lactate was measured from the highest lactate recorded while in the operating room minus the baseline that was measured shortly after placing the arterial line. Again, the only group that showed significant difference was the robotic group, and this can be easily explained by the increase in bypass and clamp time. And on average, the increase was about 1, which isn't something that we're typically concerned about, that level. And then last, I just did quick transfer and demand calculations for each patient while on bypass to ensure that the transfer was in fact higher than demand throughout the case. It was found that for 100% of patients, adequate flow was being provided, and when comparing that value of transfer minus demand between the groups, the differences were found to be insignificant, which shows that the flow was meeting metabolic demand for all groups. So conclusions, overall the results of this study, results of this study show that minimally invasive. So overall, the results of the study show that the hypothesis was partially supported. The mini group through mini thoracotomy actually did not have significant increase in bypass times. However, the robotic group was significantly longer. Also, it was proven that both techniques were able to provide adequate perfusion, though some of the indicators of adequate perfusion did have significant differences. The surgical team was still able to manage the patient, and average values were still within the parameters for what is acceptable in patient care. As surgical skill continues to improve, minimally invasive techniques, especially with the use of robotics, will become even more popular. And like we saw from Dr. Romley's talk earlier, it's important that us as perfusionists are aware and educate ourselves on what some of these sacrifices will be and challenges as far as the perfusion side of things. And we must also stay involved and relevant in the progression of these techniques. In the end, the operative approach that is used should be catered to what is best for the patient and will lead to the best outcome. With all of the prior research and information that's been pointed out, it's very likely that mini and robotic procedures will grow to be the standard of care. So just a couple limitations to my study. This was a single center study and not a very large population. Also, some of the data was collected from paper charting. This was an experienced surgical group and anesthesia team, which helps to compensate for some of the disadvantages of lower flows. So this study was conducted at a center that had decades of experience with all 3 techniques, which caused the variables to have good control. But when adopting any of these techniques at a new center, it's important to keep in mind the learning curve and be aware of the surgical team may need to compensate. So for my acknowledgments, I just want to acknowledge my program director, Richard Chan, and then all of my amazing preceptors over the last 2 years, my classmates, and then the Perfusion.com team for having me here today. This has just been a really great experience. You guys have been really generous to all us students, and thank you. And some references. Thank you.
Thank you, Jessica. Great presentation also. I have a question for you here. What are some of the reasons for the significant lower blood pressure during the robotic procedures?
So other than just the correlation of lower flow leading to the lower blood pressure, with this they use the endoclamp system. So it was this surgeon's preference that they really want to keep the blood pressure within a specific